Although the title is ultrasound imaging, I will include some of them, I will images because some of the complications of cesarean cannot be visualized very well by ultrasound. So I start that with the topic and I will show you how the uterus postpartum will look like. This is the normal postpartum uterus, and this is the area of section. Here you can see hypoechoic area, which is a normal finding. And this is the area of the EMR section. Here are the strictures that you can see that of the vagina. This is a CT scan of the cellular finding. This is the anus area, this is the anus area, and area of hemorrhage. And if you have a small hematoma in that area, 1.5 centimeters, this is considered as normal. Here is the normal endometrium postpartum. We don't have a lot of fluid within the endometrium, and we don't have a lot of fluid in the pelvis unless we have the negative mass. This is the edema in the skin, and this is quite common. What happens in some conditions? We know that in time we have encountered a lot and increase in the rate of C-section, and thus a lot of complications of C-section. And we have to be aware of these complications and try to catch them as soon as possible because some are even life-threatening. This is, as you can see, this is the uterus with lots of fluid and uterine. And this therapy has a lot of fluid within it. This is typical of obtaining products of conception. Whether they are infected or not, that's a possibility. We have to follow the clinical European judgment at the time. This is an ST of the same of the similar case. This is bright spot is indeed product of conception, and this is the normal postpartum scar. Hematomas can develop in the scar and can be at different levels. This is a subcutaneous hematoma. Sometimes you can see gas in the bladder, in the pelvis, and within the uterus. This is normal because we often have all of these images before. This is a yeast scar with a subcutaneous hematoma, and it's superficial because it is above the rectus muscle. So all of you look for the rectus muscle to differentiate the different types of hematomas that you see. This is a subfacial hematoma, so it is under the rectus muscle, but it is infrared, it is supraperitoneal. So we don't have to decide. We need to drain this hematoma. We don't go intraperitoneal. So this is a quite a big hematoma, which is under the rectus muscle. Whereas this is a small subfacial hematoma. It is not unusual. A hematoma which is around 4 centimeters in the postpartum period is acceptable. However, if it becomes bigger and associated with other symptoms and anemia, this is very significant. You can see the lining of the uterus and the area of the scar, which is also a normal finding. This is a CT with a bladder hematoma. You see that it is a big one, and it is endemic in the bladder. You can see the staples and edema as a view. Here, this is a CT with intra-abdominal hemorrhage and a large clot in the posterior sac. So different levels of hematomas. First thing that one happens for these hematomas is infection, and this is very common when we have hematomas, big hematomas. How can we tell that this is an infection versus just a hematoma? It's also important to stress that clinical presentation of the patient. But we have a lot of irregularity, cavities, and gas in the area leading. This means that body is an infected thing. So we have here a CT that shows hydrocephalus. This is lots of fluid with gas in it. This is an ultrasound that shows an infected bladder abscess. This is also gas that causes appears bright and causes lots of shedding. This is also an infected bladder hematoma. Notice the big hematoma with the gas here. This is all again normal. Here we have one specific type of infection that's not directly related to the scar, but that is more frequently with C-section, like just septic virus. This, you notice that this ovarian vein, the ovarian vein, is enlarged with an increased activation in the periphery, activation in the and compared to the other ovarian vein. This is again a ovarian vein virus, very large vein on low activation enhancing water or hydrodynamic water. How can we detect that the scar of this section the patient presents after delivery with symptoms like bloating, like extension? You suspect that you have lesions in your C-section scar. How can we tell that it's disease or rupture? There's quite an overlap in the findings between normal and abnormal, also correlated with the children. These happen when we see hematoma, between irregularity or interruption of the scar with presence of hematoma. Hematoma can be subfacial, can be also intraperitoneal. The hematoma usually communicates with the endometrial cavity. And sometimes we have to do color doctor to rule out an aneurysm or a useful in this case. This is a very obvious picture of diseases. Why is it diseases? Because here we have the cirrhosis intact. So the only difference between diseases and complete rupture is whether the cirrhosis is intact or not. So you can see this is the endometrial lining and the big hematoma that's communicating. They are communicating together through a uterine. Obviously, your C-section has done wrong. Here we have also an infection, pyotritis. So we have a significant use of color within the endometrium, and we have this defect in the uterus. This is a complete uterine rupture. So when the sclerosa is disrupted, this means that it is a complete rupture. Just to see that sometimes you can write pieces conservatively and drain and not introduce surgically. Whereas in uterine rupture, very frequently you have to introduce surgically. This is a CT scan where we have hematoma. This hematoma is communicating with another one in the pelvis, going to the cortical. And this is what a big hematoma. Also, this indicates a uterine rupture. There is this type already. This is gas, so it's an infection with a communication between the uterus, and this communication goes all the way to the abdominal wall. So it's an infected pyotritis with the infection very low, going all the way to the abdominal wall. This is a similar image with the high record of gas in the infected uterus. Sometimes these cases will end up in hysterectomies. I will skip here. This is an ultrasound because I talked about that we need to have some ultrasound pictures. This is an ultrasound picture of the subfacial hematoma. Also, this is infected with Cayman access, and there is gas in it. You can see clearly that for hematomas and things involving the abdominal wall, CT and MRI are much better than ultrasound, especially that if you put a probe on this patient and you press it on it, the patient will be injured. So probably CT scans and MRIs are much better modalities for this problem. This is a similar picture, heterogeneous endometrial fluid going all the way to the submucous, also a state fracture. What happens in the pregnancies? Here, you do a C-section and break down with years or months later, you look at the patient, what can you see? Most of the references say that you can see the area of the scar. It is that scar in the body, you can see it. And it can be visualized by ultrasound. Some will say it is even visualized in 100% of the cases. So this line is the scar, and this is shadowing from bicycles. This is also the area of the scar and shadowing. Here we can, this is an MRI. You can see that molecular echo, and you can see that this patient has had two previous sections. There is an outlet between this, and the molecule has gathered into the mind. And you can see how it turned out the mind has become. And this is important because there are studies that would like to correlate the remaining residual molecular thickness with subsequent dry rupture in the future. No correlation we have the all, but there are certain things that are limited. So this is what we call it, just imagination or reflection or indentation in the area of the scar. Sometimes it is triangular and subtle shapes. This is what we call the depth of the niche. And this is the residual line, and this is the local intraannual, the intraannual. We have different shapes, and you can see it in depending on the modality. If you look at the sound, you can see it in like 30%, 50% of the cases, whereas if you do solo or Cesarean, you might see it much more frequently. So this is a semicircular niche, this is triangular, this is teardrop, this is like output. The importance of this is that some patients present to you with irregular bleeding. This niche acts like a reservoir. The muscular blood will collect there, and then the whole cycle, the lining has some fluid in it, and this blood continues to the patient continues to spark throughout the cycle. So it's also associated sometimes with dystonia or dystonia and chronic. So patients with a niche that's apparent on ultrasound would have more likely postnasal sparkling days of respiration and days of intramuscular bleeding. The patient's sponsor now is not directly related only to the depth of the scar. It is related to the total volume of the niche. These are several, this is the expert hormone. The location of the niche can be determined, and we have different shapes and nomenclatures to label or describe the type of incision. I skip this because these are historical ground features and we don't have a lot of time. During pregnancy, we can also see the scar, and this is the scar in an early pregnancy. These are several things, but the scar can be seen. The width of the scar, if it is 2 millimeters or more, some people will view it at this and this is scar during pregnancy. So if you have a 2 millimeter width of this scar, some people would try to figure out whether it is another sign of subsequent rupture. The location of the niche in relation to the internal osseous union. So, in some most of the features are actually present within the cervical portion, irrespective of whether the patient has labor, whether it's multiple C-sections or one C-section. Let me show you this. During pregnancy, we have variation in the width, length, medial milestone, and the scar depth. Usually, this is the median progression from the first, second, and third trimester of these factors. If, for some reason, some patients do not follow these curves, these are the ones that are more likely to have rupture. Of course, we need very good numbers in order to tell or to try to predict if these patients are the ones that will rupture, because out of big studies, only we had a few cases of uterine rupture, and the only characteristic was, even before the same pattern, the residual molecule increased a lot during pregnancy. This is an ultrasound. Also, the uterine rupture cannot be seen very easily by ultrasound unless you can see some fetal part or membrane culture. This is a rupture, the notice that was out. This is, you can see how there is there is diluting from the frontal part of the probably this is an area of previously anesthesia. This is the area where you can see several kinds of diseases. You can see the molecule that is interrupted and there is no good continuity, and this is on my arm. I'll skip these, and I will talk just also we can detect complications of C-section by CT cystograms when you suspect that you have a fistula. So this is a bladder with a fistula with the time and the positive. Another complication is adhesions, and you always wonder when you see some patients why you cannot see the adhesions very well by that ultrasound. This is typically when you have adhesions, the surface is below the lobular segment is attached to the anterior abdominal wall, and there is retroflexion of the fundus. So this is why it's difficult to see it on lung ultrasound. It's better to see it on abdominal ultrasound, but without feeling the belly, or else you will not see it very well. So you can see this is secondary adhesions. What's interesting is that sometimes you can see adhesions within the uterus itself, and you can see them floating near the baby. And there are reports where there's this like an annual gland where you can have fetal parts on one side or the other. My position IUD also can be seen. This is an IUD as well, directly in the skull. One of the arms is obviously in the skull. Abdominal wall is reduced. You can see also by ultrasound, and this is like some tissue mass that can be substituted and be exported. But we need a abdominal ultrasound which is 12 millimeters because the linear transducer rather than curvy linear. And the history is very important. You see the patient with really of cyclic linear to unsize returns to cycle. This means that college has been abdominal wall introduces. We usually have good flow in them, and they appear very tight on MRI. Let me talk a little bit about findings in cesarean pregnancy. We are encountering more and more these kinds of complications, and these are very serious complications that can cause bleeding and even death in some patients, not many death. Diagnosis cesarean pregnancy, the uterus should be anterior, cervix is anterior, and the sac should be in the area of the lower uterine segment, in the area of the skull. And usually there is thinning of the myometrium anterior to the sac. And sometimes the nuclear cavity is restored by the current of the sac. This is a typical cesarean scar pregnancy. You can see anterior. This is the sac with a lot of fluid. Usually with color doctor you can see a lot of fluid within the scar, cesarean scar pregnancy. This is a MRI of the same place. Also, this is an ultrasound. Ultrasound is the first diagnostic modality. Sometimes some authors will say this is the only modality that we need in order to confirm the presence of cesarean scar pregnancy. This is an early cesarean scar pregnancy, later, and this is how you can see thinning of the endometrium. This is the uterus. This is the pre-cervical stability, and you can see the endometrium around the cesarean scar pregnancy, and this is the endometrium. It can be delineated better. Usually, a cesarean scar pregnancy occurs when goes to a fistulous tract or the skull is already decreased, and it allows a bigger surface area for implantation of cesarean scar pregnancy. Usually, with the doctor, you can see a low resistance flow in that cesarean scar pregnancy. Lots of vessels, and this is how it looks like when on the microscope. In addition, about pregnancy associated with irregular pregnancy, and this is actually a big guide on what to do in these cases. Also, there have been reports of a molar pregnancy, which is a cesarean molar pregnancy, which is two-fold of parameters. The last thing that I will mention is acne, placenta means problems. The signs of placenta acne are loss of the normal hypoechoic or subplacental tear space, irregular vascular sneezes or acne within the placenta, bulging of the pregnancy into the uterine wall, interruptions of the uterine ureter interface, and extension of placental tissues into the bladder or adjacent organs. Our doctor will help you in the diagnosis when we see a gap in the continuous retroplacental flow that we have turbulent flow, irregular linear vascular channels that extend from placenta to myometrium. Also, the blood vessels would be surrounding the myometrium in the placenta and ureter. There is hypervascularity in the bladder wall, and color doctor usually see low resistance flow in these areas. The MRI will show a similar picture, but because it has very soft tissue contrast, sometimes you can easily see the differentiating things between the placenta and the various organs. One characteristic clue that is present on MRI, and in one of the questions they mentioned that this is the best clue, is that you have a hypointerest band that presents fibrillary condition. I'll show you a few pictures. This is the echogenic bladder line. This is what is disrupted, and then we have some intrusion into the bladder. This is a 13-week pregnancy with loss of blood cleaning, absence of retroplacental translucent space, loss of blood cleaning. This is a 3D picture that helps in telling us that actually the echogenic line is intact. This is an MRI that helps you, that shows you the disruption in the